Good evening, colleagues. I welcome those that we have not met before. I'm Dr. David Mkwanazi, an occupational medical practitioner, exposure scientist, health professions educator, but most importantly, your colleague. Occupational Health and Exposure Sciences Academy aims to always save workers, strengthen industries, and enriching you, the occupational health professional, with knowledge. This session is proudly brought to you by Occupational Health and Exposure Sciences Academy in partnership with colleagues from Stellenbosch University and Masakane Strategic Health Consulting. Please allow me to go through a couple of house rules before we can start. This session is accredited for 1 clinical CPD point by HPCSA and for South African Nursing Council registered participant. South African Nursing Council attendees should contact Lebohan to guide them on how to upload their points. The CPD point will be allocated to colleagues who have subscribed, and colleagues still have the opportunity to finalize that with Lebohan before we submit to HPCSA. Colleagues who do not wish to receive CPD points are welcome to attend this session for free to enrich their knowledge. Kindly please drop your HPCSA number or council number, full names, and email address in the chat box to register for CPDs. For those who are not registered with HPCSA and South African Nursing Council, an attendance certificate will be issued to demonstrate your growing knowledge capacity in areas covered by our platform. Please keep yourself muted at all times to avoid interrupting the presenters. Disruptive attendees will be removed from the webinar and will not be able to join again. This session's attendance will be monitored for its entire duration to ensure full attendance. Kindly please ensure that you do not join using nicknames or handset device names to be properly identified and allocated your points. Each session will be podcasted on YouTube for long-term education and training purposes. We have realized that many colleagues go back to our YouTube page to recap on the information that may have been missed during the sessions. We also urge you to post your questions on that video platform to continue empowering colleagues who will always be able to access our learning material. The link that you have used today to join this session is a recurring link and can be used every month on the last Thursday until the end of the year. Participants will be allowed to ask questions or comment after each session, but you are welcome to post your questions in the chat box as the session continues. Questions can be posted in the chat box anytime, as I've indicated, or after the presentation. Our sessions are multidisciplinary in nature and are meant to empower colleagues from different professional backgrounds. Kindly please be patient during moments when we discuss topics that may not be relevant to you, but others. We do have two packages. The first package is for 6 CPDs in total. It's a monthly webinar session attendance on the last day of the month, where we offer 1 CPD point per session. This will go on until the end of January. And the second package consists of the monthly refresher sessions, the 3-hour sessions that we have every month, consisting of 3 CPD points per session, plus you get subscription for these Thursday sessions for free, all until the end of January. In the upcoming month, on the 13th of June, we have a health risk assessment refresher webinar, which will run between 10 a.m. and 1 p.m. This is a previously recorded session that we've had previously. And on the 27th of June, we will have a new refresher on managing abnormal findings in medical surveillance. And that will run from 9 a.m. to 12 p.m., accredited for 3 CPD points. In today's session, we are going to look at the approach to workplace spirometry, which will cover technical and clinical aspects. And in the latter part of the session, we will look at the modern silicosis, the global lessons for occupational health practice. Spirometry forms the core part of our professional practice and aims to screen workers for respiratory symptoms while also playing an important role in detection and diagnosis of different occupational lung diseases. In her 2012 paper titled Interpreting Spirometry in the Occupational Setting, van der Lende concludes that spirometry interpretation is a step-by-step process taking into account equipment verification and calibration, the use of correct predicted values together with correction of ethnic origin, and the reliability of data by applying acceptability and repeatability criteria. In a world where prevalence of global silicosis accounts for as much as 10 to 30%, it is very important to clearly understand exposure scenarios in order to design control strategies that not only save the lives of affected workers, but also create healthier and safer workplaces. Please join us this evening as our speakers share their knowledge and empower us to approach our workplace scenarios with confidence and skills to make a difference. To help us navigate the topic of spirometry expertly, and we are honored to welcome Dr. Caspar Joubert, who is a final year occupational medicine registrar at Stellenbosch University and Tygerberg Hospital in Cape Town, South Africa. He has published in the Journal of Occupational Health Southern Africa and currently serves as the College of Public Health Medicine Committee. He previously served as a chair of the Western Cape chapter of the South African Society of Occupational Medicine. With a diverse clinical background spanning 3 countries, namely South Africa, United Arab Emirates, and Mauritius, Dr. Joubert brings a global perspective to occupational health practice. His professional interests include digital health innovation, risk management, and the ethical integration of artificial intelligence into workplace medicine. Beyond his medical career, he is an enthusiastic traveler, runner, and golfer, finding balance between professional commitment and personal well-being. Please allow us to welcome Dr. Joubert. Caspar, are you here?
I am here. I would like to listen to this Dr. Joubert. He seems like an impressive person, so I'm looking forward to his presentation.
Welcome, welcome. It is indeed an honor to have you on our platform. May I please ask if you are able to share from your side?
Okay, Um,
I'm
let's
going to
see.
stop sharing now so that you can
Okay,
share from your side. Yes, we can see your slides.
there we go. If I can just get a confirmation that we are ready to go.
Yes, we are. Please take it away.
Thank you very much. Right. Good evening, colleagues. The last time I glanced, there was over 108 delegates on this call. What a fantastic um, sort of opportunity to speak to so many of colleagues that are interested in looking after the health and well-being of people of the working cohort in South Africa. And I'm excited that there are so many people that are willing to give up a Thursday evening to sort of expand their knowledge. So let's see if we can learn together. Well, I was asked to talk on practical spirometry and specifically, within the occupational medicine space, such a valuable tool. And I think something that is not that well taught in an undergraduate level, and certainly in the primary healthcare space, we don't see it as much. And so hopefully a couple of the tips and tricks and things that we're going to talk about tonight will be advantageous to you all in your practices wherever you may find yourself. And I think the first apt quotation to start with is to say that the only thing worse than doing spirometry badly is not knowing that you are doing it badly. And that was a beautiful quote from Enright and Ruppel. And I think that it's perhaps worth reflecting on that, in that if you are doing spirometry in your practice, make sure that you know what you are doing. Don't dabble in things that you are uncomfortable with. Certainly, there's no shame in asking and learning before taking the step in doing it yourself. I'm going to try and go through the slides a little bit at a quicker pace. There's a lot to cover, and perhaps then leave a little bit more space for questions at the end, where we can then move back to specific slides if that is appropriate. All right, so why should we care about spirometry? Well, there's several reasons why spirometry is an important tool in the occupational medicine practitioner's toolkit. Although the first block says here diagnosis, spirometry doesn't really diagnose illnesses in the sense that it creates supportive evidence to support a diagnosis. So from an OMP's point of view, some of the things that are really important is to look at signs and symptoms of your workers, to screen some of your workers for pulmonary disease, and to look at the prognostic factors that they might, or some of the prognostic factors in terms of people with already established disease. Monitoring, of course, is something that we do quite a lot of. We want to see the disease progression, and we want to define it. And then, of course, we want to look at people that have been exposed to certain agents and try and pick up adverse effects. Some of you might be in the disability and impairment space, and here we do these tests to evaluate the individuals, to create a value of their impairment. And for those of you familiar with the TB regulations, you will know that after treatment, you want to evaluate the person for permanent disability. And then there's other reasons such as research, clinical trials, pre-employment, etc., etc. So there's quite a wide range of why we would use spirometry and why we should have a working knowledge of spirometry. Okay, so what information can we get from spirometry? And here it starts to get a little bit tricky. Just bear with me. We're going to go through these terms repetitively. And I think this is one of those, the next two slides are those types of aspects that there's nothing to understand or very little to understand. It's really about creating creating memories and really sitting down and just sort of committing it to heart. So the first thing is, of course, the forced vital capacity. And so that is defined as the maximum volume that you can forcibly exhale after full inspiration. Okay, so that is important. So the forced vital capacity, and I'll on the next slide, I'll show you a graphic representation. Then another value that's very important is this forced expiratory volume in 1 second. And so that is the amount of air that you can expel in 1 second. Of course, we then use a ratio of these two, and this ratio acts as a sort of gatekeeper later on when we talk about how to interpret these values that we have found. We can also see the peak expiratory flow, which is similar to the handheld peak expiratory flow monitor that you have or might be used to. And then the FEF, they've got some different names, but 25 to 75, and essentially it looks at the small airways, and so can give you an idea of what's happening in the smaller airways. Right. So when it comes to lung volumes, this graph here on the right-hand side of your screen is really important. And I would suggest that you spend some time to commit this to memory. In short, what you want to know is that we always have a tidal volume where we're just comfortably breathing in and out. Then we've got a inspiratory reserve volume. We've got an expiratory reserve volume. And when you start adding several volumes together, you get a capacity. So volumes summed together gives you capacity. So here you can see that your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume gives you the vital capacity. And that is that name that you've heard on the previous slide, essentially the forced vital capacity. What is important just from a graphical representation is to note the residual volume. And this will come into play later on when we look at total lung capacities. So I've already mentioned what spirometry can tell you, but it is important to understand what it cannot tell you. And spirometry, as part of the umbrella term of lung function tests, so remember, this is very specific. We're talking about spirometry. It cannot tell you what the total lung capacity is. It cannot tell you what the residual volume is, and it cannot tell you what the functional residual capacity is. And the reason why it can't do any of those things is essentially because you don't have a residual volume. Well, you can't just whip somebody into your office and start blowing. You need to think about relative contraindications. Now, as an OMP, you have to ask yourself, why am I doing this? Why am I committing person to this test? Remember, the basic, I think it's the Employment Equity Act, Section 7 speaks about medical testing, and you need to be very, very clear about why you are doing this test. So when you ask why, you must also ask, is it safe within our context? So there's a couple of main categories that I would suggest you think of. And the first is cardiovascular. So did the person have a myocardial infarct within the last week? Do they have severe or uncontrolled hypertension? Is there significant arrhythmia and history related to syncopes? Now, I would suggest that it is no business of the OMP to be doing a spirometry test if any of those are even remotely on the cards. I would be hard stretched to imagine why you would be doing it in these acute situations, but nonetheless important to think about it. Then moving on to the thoracic and abdominal contraindications, think about surgeries, think about active pneumothoraxes or pneumothoraces, and then also think about pregnancy. Why would you be doing this when your result is not going to be useful in that sense? From a neurological and ocular point of view, you need to think about cerebral aneurysms, brain surgery within 4 weeks, recent concussions, eye surgeries, and then also sinus and middle ear surgeries. And then from an infection control, one of the main ones that we see is tuberculosis. So you would want at least somebody to have been on therapeutic treatment for a couple of weeks. And if you're not sure, ask yourself, can I postpone this for another 4 weeks, 8 weeks, 12 weeks? There's really no rush in most cases to do these things. Okay, so what must we tell our patients before they arrive? Well, you want them to avoid certain things. So they mustn't exercise. They shouldn't really be intoxicated or have had intoxicants before arriving. You want them to be comfortable, so no restrictive or tight clothing. And definitely you don't want them to be smoking. In certain circumstances, you also need to talk to them about their bronchodilatory medication, and depending on the severity and understanding the clinical context, advise them to withhold their medication. And then on arrival, and these things are really, really important. You want to get the height of the person. You want to get their birth sex, because that determines or plays into the determinants of lung size. Ethnicity, similar. And then you want to make sure that you've got the checklist in terms of the medications, the contraindications, any acute illnesses, and watch out for those dangers. I'm going to really briefly touch on this slide. It is important to make sure that your machine is calibrated. An uncalibrated machine creates invalid results. And so this will differ for different machines, especially if you have more of your office-based machines versus your more technically sophisticated ones. But there's some basic principles related to this, sufficient to say, make sure that you've got a daily quality assurance list that you can go through. This is very, very important and worth standing still for a minute. The adage, junk in, junk out, comes to mind here. For those of you that have done lung function tests, it is actually not that easy to get full cooperation from a patient. And it's really worth reflecting on this slide, making sure that you understand the phases and that you've got the language to communicate to your patient how best to do this test. So you want to really be quite animated. You want to understand what's going to happen. You want to coach them throughout the process, and you want to be there right next to their side saying, go, 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 don't stop, and really be, sort of, like I say, quite animated, because that ultimately determines the quality of the outcome. So how do you do that? Well, first of all, you understand that coaching is important, but you want to watch the patient, so don't just be uninterested, looking at their face, understanding, are they putting in, the best effort? As it says here, nobody is comfortable when they are going at full inspiration and expiration. So somebody shouldn't be looking comfortable. You want to be quite adamant and active with your words, saying more, go, give me all, everything, and out. So really use your energy levels to inspire the patient. It's important to use the no fault principle when speaking to them, and because again, it's not quite that easy to do these tests. And so you want to say, what happened here was this, would like to aim for this. So don't judge the patient, because obviously that is going to make them sort of withdraw and give you less accurate results. Oftentimes, some of the newer machines can use or have built-in tools in the screen. We know the little flame. So sometimes it will say, blow the flame. And there's all these sort of digital tools that one could use to aid you. You would want to know when to take a break, because it is quite tough to do this. And so make sure that you're sensitive to the individual's energy expenditure. And then you want to document your observations. And this is always very important because you want to make sure that you can compare like for like in the future. Right. So, Dave, don't you want to just, I think there's somebody whose mic is on that's coming through every now and then. If you can just look at that for me, please. Um, then there's the within maneuver acceptability and the repeatability. Now, this is one of those, again, some of those academic aspects of the lecture that you probably just need to know. Again, if you don't fulfill the acceptability and reproducibility criteria of spirometry, it is not valid. Okay. So what are we looking for? Well, we're looking for a good start. There's a very sort of technical definition in terms of the back extrapolated volume. Most machines will just calculate that in and of itself. You want to see that they are unhesitant and that the peak flow is close to the zero with a nice sharp rise. You don't want to see any coughs in the first second, and this is sort of indicated as a little squiggle. You don't want to see any glottic closures. And again, another one of these sort of very technical aspects is the peak flow rise time should be short. Again, that typically the machine will give you an answer for, because you won't be able to calculate that on the printout. There are three criteria for end of forced expiration. So how do you know the individual has completed their expiration? And so one is you want to look for a plateau where there's less than 25 milliliters of change in the last second. If in your obstructed patients, especially, you see a forced expiratory time of more than 15 seconds, then you can stop them. Or if you fail on both of these, your FEC matches its prior FEC within the reputability criteria. Again, very, very important to make sure that you achieve the acceptability criteria and that you are well versed in what this criteria entails. We are then looking at between maneuver evaluations. Okay, so not only must your spirogram be acceptable, but you want it to be repeatable. So what does that look like? That's a little bit easier. You want 3 acceptable measurements. Okay, so as I mentioned before, so you check for acceptability, and now you want 3 of those. And then the 2 largest FECs and FEV1. So they must both be within 150 milliliters of one another. So that is really, really important. And of course, you shouldn't be looking at more than 8 maximum maneuvers. It is very difficult to even get close to that. Once you have done your acceptability and repeatability checks, then you need to grade the quality of your spirogram. And again, you know, we don't always go into the detail, but you want to just have an idea of, no, this is an F. You know, this is so poor, I can't really even say anything about this. This is an A, wonderful. This is exactly what I need. And so most of the spirograms that we sort of deal with falls between the A and B criteria. And we're quite sort of strict in the tertiary unit, where if it falls below that, then we often will just say, look, we can't make or whatever comments we are making, we are reserving our commentary because of the fact that the grading is ideal. So what we are talking about next is sort of a bit more of the again, academic, in-depth sort of understanding about the references. And you will see that one of the first things that you look at when you've got this printout is you want to make sure that the demographics of the individual is correct. You want to make sure that their ethnicity is correct, their age, height, weight, all of those things, as well as I've mentioned, the ethnicity, but as well as the standard that you are using for the predicted values. The current gold standard is the GLI 2012, and that's what we use. And essentially, this is validated reference equations to the standard that your patient is going to be held or measured. And then quite recently, well, perhaps not as recently anymore, we've moved away from a percentage predicted model. Now, most organizations ask that we move into the Z-score or lower limit of normal, which is essentially a statistical cutoff value for interpretation. Within South Africa and mostly within, well, definitely within the tertiary setting, our printouts will have both of these included, so that if you are still using the percentage predicted model, you can still use the spirogram. But as I said, for various technical reasons, you would want to use the lower limit of normal. So how do we interpret our spirometry? Right. So first of all, you've got your printout. Number one, you look at the demographics. Okay. So you want to make sure, just like we were all taught, when you evaluate any test, is this test belonging to the individual, and was the information provided correct? Then you have to have a clinical context. You have to have a clinical context. You must understand, what was I looking for? Why did I have the test? Okay. Then you look at, is the test quality adequate? So looking at your acceptability and looking at your reproducibility criteria. Now you can look at the ratio. So you look at the FEV1 FVC ratio, and it's the gatekeeper. Is it below the lower limit of normal or less than 0.7 or 70%? Immediately you're going to the obstructive pattern. All right. Then you can evaluate your FVC. Now, if it is yes, this graph doesn't show it so well. I'll show it on the next one. If you have an obstructive pattern plus an FVC that is low, then you're looking at a possible mixed disorder. If it is an obstructive pattern with an FVC normal, then that is just obstruction. And of course, if the FVC is not below the LLN, so normal or above 70%, then you can again look at the FVC. If the FVC is normal, so you've got normal here, then that is normal. Or FVC normal, ratio normal, FVC abnormal or below the LLN, then we use the words possible restriction. You cannot make the definitive diagnosis of restriction on spirometry. Then, of course, you want to grade the severity, both for obstruction and restriction. But when it is obstruction, you're also going to have a look at the bronchodilatory response or response. This is actually much better to understand, and my brain works a little bit better. They say pulmonologists The mathematics that they like is lung division. So here's a bit of lung division for you guys in terms of ratios. So if you are going down the lower limit of normal, or the fifth percentile, then you want to do, is it essentially normal? Yes, it's normal. Is my FVC normal? Yes, then it's normal spirometry. Is my ratio normal? Yes. Um, is my FVC normal? No, it's not. Then you can say there's a possible restrictive pattern. And outside of the scope of tonight's lecture, you will then use more specialized tests to further evaluate. Is my ratio normal? No, my ratio is not normal. Then is my FEC normal? Yes. Then we've got, let's call it simple obstruction. Is my FEC normal? No, it's not. Then I've got a possible mixed disorder. There's one block that sometimes sits here where we talk about hyperresponsive, sorry, not hyperresponsive, bronchodilatory response test. This diagram and this flow diagram are exactly the same. Here you can just see that they use ratios. Okay. And I think perhaps the most important thing is you want to know, what is the ratio? Is the ratio low, less than 70? Is it more than 70? If it's less than 70, then you're looking at a possible obstructive pattern. Is it more than 70? Possible restrictive. And then you add your FVC in to sort of add even further and more definition to your diagnostic process. So this is just basically sort of talking again about what we've mentioned on the previous slide. You want to look at that ratio. That is where it's all at. Or, as I said, the lower limit of normal. Then you can also look at your flow volume loop. We're going to explore that. Then you want to look in terms of the, if you've got an obstructive pattern, then you want to look at your post-bronchodilatory response. And there's certain criteria for certain illnesses. And then very important to remember that your severity on spirometry is not equal to clinical disease spirometry. We see this quite often. As I've mentioned, you will then use your FEV1 score to create a sort of a score in terms of how severe their results were. And this score uses Z values, or the Z values, to create these categories. Again, there is corresponding percentage scores for these categories as well. Reiterating what we've said, you want to basically funnel your brain into, is this a restrictive pattern? Is this an obstructive pattern? Or is this a mixed pattern? And again, really starting to focus on that FEV1, FEC sort of ratio, and then looking at the FEC as well to help you navigate down those flow diagrams. And what these pictures can then help you develop is push you into a direction in terms of possible clinical conditions. But again, the spirometry is not the definitive aspect within that final decision-making process. You really want to base it or use it as a confirmation of what you are already seeing. Here's some of the different types of patterns that you can see. And so whilst you know, there are those very clear flow charts, you want to also look at the visual representation. So here you want to see a sharp rise, so very close, nice peak tent that is possibly even a little bit too much rounded. You want to really see a sharp angle there, and then going all the way, not stopping short. So you don't want to see that sort of stopping short. There's no cough, there's no squiggles here. It's a nice smooth line going all the way to zero flow there, and then the big inspiration. And so this would be essentially the shape of a normal flow volume loop. The classic obstructive pattern is the sort of concave shape that we see here. And that is a telltale sign of the obstructive pattern, and something that one would be looking forward to or looking out for when you are seeing that your FEV1 FVC ratio is lower is lower than the lower limit of normal, or less than 0.7%. The restrictive flow volume loop is the so-called mini-me. It can sometimes look like a normal one, but much smaller. So you've got a lower peak flow and a lower expiration, or a smaller expiration, as well as the lower or smaller inspiratory loop. And obviously there's really good physiological reasons for this. People's lungs are stiff, so not only can't they get much air in, because they can't get much air in, the air that they push out is also of a smaller volume. When you start seeing these sort of odd-shaped flat lines, then there is some sort of obstruction occurring. If this doesn't match up with the clinical features of the patient, make sure that it isn't a technical aspect that you might be dealing with. But typically, I don't expect you to be seeing these types of patients in the clinic. Let's talk about the bronchodilatory responsive test, and this is very important when we come to the definition and the diagnostic criteria of asthma. Now, I won't go through all the different types or multitude of different ways to diagnose asthma. Just to say, according to the GINA guidelines, which is obviously the gold standard within the asthma world, you would look at a positive bronchodilatory response for as one of the major criteria for diagnosing asthma. And as OMPs, this is obviously also very, very important when we're talking about occupational asthma. Remember, as per the regulations, you must first diagnose asthma before you can diagnose occupational asthma. And what they want is either an FEV1 or an FVC that increases by both 12% and 200 milliliters. So this is very, very important. And so also, there are some other criteria. We need to look at bronchodilatory response times for withholding. Otherwise, obviously, it will be influencing your test. I'm going to run through these last slides. You want to make sure that you don't cause these common errors. Really inspire the person to give them their best. Don't let them hesitate. Make sure those technical aspects are checked. Look for mechanical or equipment failure. Watch out for those coughs, and obviously the rest is your calibration. And make sure that when there is an obstructive pattern, you're doing a post-bronchodilatory test. In the occupational medicine space, we do this for a variety of reasons. And, like I said, it is really important to just understand why you're doing this, looking at establishing a quality baseline. What is the normal decline that you can expect? Clinically significant change, especially within occupational diseases. Then you want to grade and do the same thing all the time. I will skip over the case because I think my time is going to run out. But I think just as a wrapping up, 10 things that you want to remember. You must verify your equipment. You want to prepare the patient before they walk through the door. Look at your energy, understand those 4 phases, grade your spirogram, look at the acceptability and reproducibility criteria. Make sure that you are understanding both the score types. We are moving to the lower limits of normal. Doing a bronchodilatory response when you are seeing the obstructive pattern and understanding what sort of action should be taken when you're doing surveillance and knowing when to pick up on these patterns. Well, with that, I say thank you. And yeah, I apologize, but this is a big topic and difficult to cram in a short time. So thank you very much.
Thank you very much, Doc. What an insightful presentation. May I please ask you to stay over for a few questions after the session? I see there is a question waiting for you. Colleagues, please continue posting questions throughout the second presentation, and then we'll take questions shortly after that. I'm going to ask you to post your questions in the chat room so that we don't disrupt the flow. Now, a subject as complex and critical as silicosis requires expert guidance from a skillful and experienced medical professional who, amongst many achievements, has authored and published a book on occupational lung disease. Dr. Vanessa Cavenda is an occupational medicine specialist, author, keynote speaker, and director of Masakani Strategic Health Consulting. She's widely recognized for her leadership roles within the South African mining companies, including Anglo American and Gold Fields, as well as construction, energy, and engineering company Adeng Group. While her work has focused extensively on occupational lung diseases, she is increasingly recognized for her interest in the responsible adoption of AI and digital innovation within mining and occupational health systems. She's an author of From Suspicion to Submission, Occupational Lung Diseases in South African Mining Industry, which was published in 2024, a handbook focused on improving clinical decision-making and prevention. In 2025, she was a finalist in the Harvard Medical School AI in Healthcare from Strategy to Implementation program, where she explored AI-enabled clinical decision support system informed by principles from her book. Dr. Govender recently participated in an academic tour to University of Iowa and the American Occupational Health Conference in the USA, where she presented on emerging approaches to surveillance, respiratory risk profiling, and early intervention strategies. Former president of Mine Medical Professions Association, MMPA, she also served as the first chairperson of MOSH Dust Adoption System, helping advance dust reduction initiative across South African mining industry. She served for several years on the MBOD certification committee and continues to contribute to discussions on compensation systems, complex occupational disease pathways, and prevention-focused worker health strategies. She's a guest lecturer with the International Labour Organization and currently involved in collaborative silicosis biomarker research with University of Witwatersrand and University of Gothenburg. That sounds overseas. A passionate public health advocate, her master's research was presented in Parliament and contributed to the amendment of tobacco regulations and helped shape her lifelong commitment to prevention, worker health, and social justice. She currently serves as a medical advisor to Tsiamiso Trust. Are you here, Dr. Govender?
I am. Good evening, Dr. Mkonazi.
It is
Can you
indeed
hear me?
to have you. Yes, I can hear you. And may I please ask you to proceed?
Thank you. I'm going to start sharing. Can you see my screen?
So far, I can see your video.
All right. Can you see the first slide?
Not yet.
Okay, just give me a moment. Ah, I did not click share.
Yes, something's coming up. Yes, Doc, we are online now. The
Okay.
slides are up.
All right. Wonderful. I'm just going to minimize this. Thank you, and good evening, colleagues. It's wonderful to be on this platform, and thank you to Ohisa, Dr. Mkwenazi, for this invitation to participate, and to my previous speaker, Dr. Juppé. That was a profound presentation. So thank you very much for setting the scene. So tonight I'd like to explore this topic of modern silicosis, and specifically what global trends and outbreaks are teaching us about occupational health practice. Now, although silicosis has traditionally been involved or associated rather with mining, we're increasingly seeing severe disease emerge in new industries, in younger workers, and often outside the traditional surveillance systems. So across many of the examples I'm going to share with you tonight, I think what we're going to see is this recurring pattern becoming evident, where hazardous exposures are not being recognized early enough, where disease is being diagnosed too late, and opportunities for prevention are being missed. So the discussion will focus then not only on the disease itself, but also on recognition, recognizing exposure, recognizing disease, and ultimately protecting workers. And we're going to go on a bit of a global tour to drive the message home. Okay, I need to advance. Just a bit of a disclosure up front that there is no financial or commercial interest in this presentation, and the materials are for you to use and cite appropriately, please, when you do so. Thank you. So in the next 20 or so minutes, I'd like to focus on four key areas. Firstly, the emerging global patterns of modern silicosis, and increasingly as we are seeing it in non-mining industries such as engineered stone and the construction industries as well. Secondly, in the South African context, where silicosis remains closely intertwined with tuberculosis, HIV, and other long-standing occupational exposure challenges. Our third objective is a practical approach to the assessment and diagnosis of silicosis. And lastly, we want to arrive at understanding these broader consequences of non-defensible decisions. And that includes compensation, medical, legal, and governance implications when we don't get things right. So ultimately, there's this shift that's required from delayed recognition to the earlier prevention of silicosis. So just a bit of context before we go into this global resurgence of silicosis, let's just look at the broader context of the occupational lung diseases. So lung diseases from occupation exposures are preventable, they are largely incurable, and yet they are under-recognized. And one of the major reasons is that occupational and non-occupational respiratory diseases often look clinically very similar. Silicosis may overlap radiographically with tuberculosis, with malignancies, with sarcoidosis, and other chronic lung diseases. In many settings, occupational exposure histories are not asked, or there's inconsistent application of diagnostic standards, or the occupational histories are poorly documented or simply unavailable, particularly in contractors, migrant workers, and post-employment populations, the vulnerable workforces. But we also see this fragmented surveillance systems and inconsistent application of some of the standards that are available and inconsistent interpretation of laws. And it becomes important because if occupational hazards are not recognized correctly, what happens? We don't diagnose correctly, we don't compensate correctly, and we don't prevent. So it's against this background that I want to share with you what modern day silicosis looks like. Now, across the world, there are some important lessons that are coming through. One of the most important lessons that I've learned, and that was actually initially where I was introduced to accelerated and acute forms, because we don't see these forms in South Africa, and particularly in our mining industries. So what happened was in 1969, the Coal Act was passed. Then there was major progress made in terms of dust control and surveillance. And we can see on this graph that from about 1970, after the act was passed, there was a bit of an uptick there. But then we see this dramatic decline and to all-time lows in about the mid-1990s. But what happened importantly was this consistent surge since about 2000. And we're only now starting to see this downtick. So what happened was the resurgence appeared to be linked to changing mining technologies, where more finer and more the finer dust particles were able to reach the deepest structures of the lungs, and there were altered exposure patterns because of the different mining technologies. So in reality, what really happened was that the surveillance systems were not adapting rapidly enough to the changing nature of the silica exposures. And ultimately, there was a silica rule that was passed where the occupational exposure levels, they call it the PELs, were significantly reduced, and they set action levels as well. And they also saw the institution of the NIOSH Coal Mine Workers 5-year surveillance program. So I think what we saw in the coal mines was reflective of what can happen in a very mature occupational health system when we let our guard down. Now, perhaps, nowhere else has it become more visible than when we look at the engineered stone industry. What happens when we let our guard down? Australia became one of the major global warning signals for modern silicosis. The engineered stone industry, commonly used for kitchen countertops, contains extremely high silica concentrations, often exceeding 90% of silica. What is particularly important is that this industry was perceived as a low-risk industry. However, once cases began emerging, particularly in Queensland, Victoria, the surveillance system started detecting severe disease in relatively young workers, often with short exposure durations. One of the major turning points was the introduction of the low-dose HRCT, which was significantly improving the case detection of silicosis when it was compared to traditional radiographic chest X-rays. Ultimately, Australia became, as we know, the first country in the world to ban the engineered stone that contained more than 1% crystalline silica. So this is an important story. It's an important story. It tells us what happens when data, when science, when medicine, and regulatory courage truly align. But what's important is that Australia was not alone in this resurgence. The United Kingdom reported its first recognized engineered stone silicosis cases in 2024, and they are still counting. Once again, the pattern was strikingly similar. Young workers, short exposure, missed disease. Many of these workers were involved in dry cutting and polishing of artificial stone worktops, as we can see here, and they were unaware. None of them were aware of medical surveillance. None of them were aware of dust monitoring practices. Unfortunately, 1 death, 2 lung transplants. And this, the 3 returned to work against medical advice. I cannot imagine how that happens, but it just goes to show the level of surveillance and fitness to work decisions and how those are actually enforced in workplaces. So again, the issue is not merely disease, it's delayed recognition of hazardous exposure patterns, delayed adaptation of surveillance systems, and this concern continues to evolve with time. Now, this is not historical. Just last week, California Occupational Safety and Health Administration, the board of the OSHA in California, moved closer towards banning engineered stone containing more than 1% silica. Now, since 2019, there were 560 cases, 31 deaths. Once again, young workers, short exposures, missed disease, possibly also inadequate respiratory protection, like the UK cases, severe disease recognized too late. So we can see, colleagues, across multiple geographies, multiple countries and industries, we are seeing the same occupational health warning patterns emerge. Modern silicosis is developing faster than traditional recognition and traditional surveillance systems were designed for. Now, despite all the advances in technology, in science, in medicine, in exposure science, regulations, silica exposure continues to contribute to a major global burden of disease and death. Current estimates suggest approximately 75,000 deaths globally linked to occupational silica exposure, including an estimated 10,000 to 15,000 silicosis-related deaths. Importantly, these numbers may very well be underestimated because disease is under-recognized, and respiratory diseases are either misclassified, underdiagnosed, or, as we've seen, never linked back to occupational exposure at all. And this becomes vital when we look at lower and middle income countries, where competing diseases such as TB further complicates recognition. And this brings us to South Africa. And the question is, are we seeing the full picture? So looking at this recent data, which was presented at the 7th Mine Occupational Health Dialogue in March, we see a substantial decline. Wonderful to see this decline over the last decade. These numbers reflect major industry efforts, particularly in the last 2 decades. And some of us who have been in the industry for 3 decades, in my case, have seen how dust control, surveillance, regulations, occupational health programs, and many of you in the audience may have been part of those initiatives. So thank you very much. That progress needs to be absolutely acknowledged. However, reported cases, so when I say reported, I mean those cases that are diagnosed, that are submitted to the MBOD, the Medical Bureau for Occupational Diseases, and those that are compensated, may not necessarily equal the true burden of disease. And note, changing exposure patterns, vulnerable workforce, contractors, post-employment ex-mine workers, our fragmented surveillance, the diagnostic complexities may all contribute to under-recognition, under-diagnosis, under-submission, and those numbers may not be reflected on this graph. So while the declining trend is encouraging, the most important question still remains, are we identifying all disease that truly exists? Because with occupational lung disease, what often remains seen are those that make it into the system. Let's look at autopsy data. The PATHOD database is one of the most sophisticated surveillance databases in the world when it comes to autopsy. And what the data here demonstrates that even though we've had all these measures taken over decades, the burden still remains substantial. Importantly, it's reminding us that silicosis in South Africa cannot be viewed in isolation from TB. In practice, us as clinicians, we are often dealing with overlapping disease, silicosis, TB, HIV, smoking-related disease, and other chronic respiratory conditions like COVID. And what this means, colleagues, is that diagnostic recognition becomes significantly more complex than simply identifying classical radiographic silicosis alone. So perhaps the bigger concern is that even these numbers may not be representing the true picture, the real burden of the disease. And perhaps this is one of the most important concepts in occupational lung disease, because when we stand on that iceberg, and that is me standing on the iceberg in Patagonia on a glacier, I only saw the beauty around me. I saw what was obvious. I saw what was visible. These 136 cases formally diagnosed and compensated in 2024 may represent only the visible portion of the burden, because beneath the waterline, sorry, this is not advancing, there we go. Beneath the waterline are workers who are diagnosed and not compensated, who are misdiagnosed, who are undiagnosed, who are misclassified, or who are just missed. So when we diagnose silicosis, when we look at the statistics, we must always ask, are we measuring the true burden, or are we measuring only the burden that is visible? Now, this concern is not unique to South Africa. In 2019, The Lancet published an editorial titled "The World is Failing on Silicosis," and I think that statement remains highly relevant today. Because despite decades of scientific knowledge, silicosis continues, as we can see, to emerge in new industries, new countries, younger populations. And importantly, the solutions are not about regulation, it's about education, leadership, robust surveillance data, and importantly, better diagnostic tools, like the ERS-ATS guidelines that Dr. Joubert shared, like the Occupational Lung Disease Handbook, which is homegrown, it's South African, and it's very South African, like the international ILO guidelines for the classification of radiographs. All of this assists us with recognition. Because without guidelines, we will literally be shooting in the dark and, of course, missing cases. Before we discuss why diagnosis is becoming increasingly complex globally and in South Africa, let's briefly have a look at what silicosis actually is. Now, at its core, silicosis is preventable but irreversible. It's an irreversible occupational lung disease caused by the inhalation of respirable crystalline silica dust, leading to pulmonary fibrosis. Now, the risk increases with intensity and duration of exposure. Respirable dust particles that are less than 10 microns are able to bypass the upper respiratory tract defense mechanisms. They enter the gas exchange regions in the alveoli, and they are engulfed by the macrophages. And this leads to macrophage death and a cascade of inflammatory mediators that becomes repetitive over time, results in the formation of the silicotic nodule, and with time it will grow and increase in size, resulting in lung tissue scarring. If initially these whorls are not radiographically visible, with time they become radiographically visible. You can see the opacities on a chest X-ray. The spectrum of silicosis exists across acute, chronic, accelerated, and complicated or progressive massive fibrosis. The most common form that we see in South Africa, typically in the mining industry, is associated with longer term exposures, between 15 to 20 years, okay? But that can be less if it's combined with more than 10 years since last exposure. So you could have somebody who was exposed to 5 years of low to high silica dust, but they have left the mines more than 10 years ago, which means their latency is now between 15 and 20 years. So for us as OMPs, recognizing these radiological patterns, understanding that silicosis presents predominantly in the upper and mid zones, and it's symmetrical, and the opacities are small, and noting that these opacities can coalesce to form these larger opacities of progressive massive fibrosis. We need to understand the context of these radiological patterns and the exposure context sitting behind them. Now, one of the reasons that I included this table, by the way, is from my handbook. One of the reasons why I included these sections extensively in my handbook is that Many clinicians feel uncertain about this pattern recognition and the practical interpretation of the ILO classification system and how it feeds into our compensation systems. So it was important for me to integrate principles of practice, legislation, and policy considerations, the clinical interpretations and compensation considerations, and to package this all together in quick reference guides, which you can find in the book. So the diagnostic complexity and the increased risk for TB in practice is substantial. And I urge you all to read the paper by our Prof. Rodney Ehrlich and to understand how these exposures impact on the TB risk. Silicosis, radiographic silicosis increases TB risk by fourfold, but silica exposure, just being exposed to dust, is an independent TB risk, even without radiographic silicosis. It's a very important point, colleagues, especially when we consider our workers who have left employment and present many years after exposure. Silica exposure and silicosis and HIV results in a multiplicative risk of about 15 times. And importantly, the TB risk persists lifelong, even after exposure stops. This is also another excellent paper by some of our colleagues, and I encourage you all to read this. So TB must always be actively excluded when you're considering a case of silicosis or any of the pneumoconiosis for that matter. So in practice, errors occur because overlapping disease patterns are not fully recognized. So how do we go about assessing and diagnosing these cases? Practically, the first step is always the occupational history. That means company names, commodity types, where the person worked, what were the exact exposures, what task was that worker doing, and what were the duration of exposure, and how exposure intensity may have changed over time. Secondly, the diagnosis requires integration of the clinical history, careful medical history, including a travel history, previous vaccination records, previous COVID tests. And importantly, it's the serial imaging of chest X-rays and HRCTs and the serial comparisons of lung function tests like spirometry and DLCO. And when we compare that to the baseline, that is true and real medical surveillance. Okay. In reality, silicosis is really based on one finding. It's really made by looking at just a single chest X-ray. And I always call it the danger of a single chest X-ray when I teach on the DOH. So it's an important point to remember. And of course, we always have to exclude other conditions. If it's a female mine worker, ensure that you've looked at underlying autoimmune diseases. So for me, the practical framework is exposure, it's the pattern, and it's the exclusion of other diseases. Because we've seen it, when recognition fails, the consequences extend well beyond clinical medicine. So let us look at some of these consequences when we get things wrong. So South Africa has seen multiple major occupational disease settlements and compensation structures that emerge from this failure. And we've seen it across asbestosis and the gold mining companies. And now we're seeing it for coal-related diseases where there's an application for a coal class action. The structures that have emerged because of these class actions include the Siamiso Trust, the Quebecer Trust, Kalahari Trust, and the Asbestos Relief Trusts. Importantly, what sits underneath many of these structures are questions around exposure recognition, surveillance, diagnosis, attribution and causality, compensation, and clinical defensibility. Because, colleagues, the consequences of misrecognition often emerge years later when occupational health decisions are challenged by workers, by insurers, by compensation systems, or even the courts. Which is why robust occupational history taking, careful pattern recognition, and defensible clinical reasoning remain so important. So what are the global lessons that are emerging from all of this? Firstly, I think it's important for us to know that silicosis is no longer confined only to traditional mining environments. We are increasingly seeing disease emerge in engineered stone, construction, and other diseases involving high-intensity silica exposure. And secondly, where traditional surveillance systems are often identifying disease too late, particularly where exposure patterns, where technology changes rapidly, our traditional surveillance systems are just not coping. Thirdly, diagnosis is becoming increasingly complex in high TB and high HIV settings. And importantly, I think occupational health decisions must always be clinically and legally defensible. Prevention always requires systems thinking. It doesn't require just the medical knowledge. It's how we apply that knowledge in the broader context that we are working in, because silicosis is preventable, but missing it should not be inevitable. Perhaps the most important global lesson from modern-day silicosis is that when we look across all these examples, from Kentucky to Australia and to South Africa, the pattern is remarkably similar. The danger of the exposure was not fully recognized early enough. In all these cases, in Kentucky, the changing mining technologies and altered exposure patterns. In Australia and California, the engineered stone was initially perceived as low risk. In the UK, the surveillance thresholds were too delayed to identify disease early. And in South Africa, despite decades of experience with silica dust exposure and TB, under recognition and missed disease still exists. So the shift required in occupational health practice is not simply more surveillance, it's earlier recognition of hazardous exposures, of abnormal patterns, and earlier recognition of disease. Because this modern day silicosis is not a failure of medicine, it's a failure of recognition. And I think that was my last slide. So thank you very much. I would urge you all to connect with me. And if you need to cite the book or any of the slides, the correct citation is here. And I really value your time and appreciate your listening in this evening. I'm open to questions. Thank you very much.
Thank you very much, Dr. Govenda. And I think the hands on your screen show how valuable this part of the session has been. And I would like to urge colleagues to switch off their video. Okay. I would like to urge colleagues to switch off their videos while we proceed with the questions. While we wait for more questions, may I please ask Dr. Joubert to maybe sum up some of the questions that I see he has responded to in the chat room. Just summarize them nicely. I don't want to go through all of them because I see they've been answered, but in case somebody hasn't had a chance to read through the chat room. So may I please ask Dr. Casper to just summarize before we continue with more questions?
Yeah, so thank you to the colleagues for the questions. I try to answer them. There's no real pattern in the questions, so it's difficult for me to summarize. I think in short, make sure you understand why you are doing the test. That's very important. And the second thing that is extremely important is we need to understand what the legislation says. I think you can't be OMP and OHNP if you don't understand what the legislation says, and so especially our compensation legislation, because essentially there's a divergence here is how you're going to treat the person clinically versus the compensatory mechanism. So I would just encourage people to go and brush up on that.
Thank you very much, Dr. Joubert. I have a question from Sandile Kimba. I think we've been focusing too much on referring for eyes and ears for, okay, maybe it's a typo, for a follow-up volume plateau is not achieved during spirometry. The forced vital capacity may be underestimated, potentially resulting in a false diagnosis of restrictive lung defect. In such cases, what clinical approach or management strategy do you recommend? I think this is meant for Dr. Casper. Oh, if a flow of, yeah, let me read it again. I think we've been focusing too much on referring for eyes and ears if a flow volume plateau is not achieved during spirometry. The forced vital capacity may be underestimated, potentially resulting in false diagnosis of a restrictive lung defect. In such cases, what clinical approach or management strategy do you recommend? Dr.
Yeah,
Kasper?
so I think the answer is already given there. You know, you recognize there's a problem with your acceptability, and you try and achieve the acceptability and reproducibility of your test. We must remember that also it is my understanding from the lung technologists that, you know, some of the in-office machines just aren't as great as the more expensive ones. And so again, um, go through your processes, go through your steps, make sure you've got everything correct. And we live in a digital world. You know, if you feel that there's something that you're uncertain about, you can send a WhatsApp to the academic institutions and just ask them to have a look. We don't need to suffer in silence anymore. And I think it's just important to make sure that you don't take any action, or even more importantly, in occupational medicine, no action, because of sort of inaccurate or poorly done tests.
All right, thank you, Doc. And Dr. Vanessa, this is for you. How earlier can you notice silicosis? Any signs and symptoms? This is from Tandegile Singo. Dr. Govenda, are you here?
Yes, thank you. Sorry, I was muted there. Thank you for that question. So just to repeat, how many is it in the chat?
Yes,
Is it in
how
the chat? I'm
earlier can
sorry.
you
Sorry.
notice, how early can you notice silicosis? Any signs and symptoms?
Right. So that's an excellent question. Thank you for that question. Um, so in terms of the signs, I think my presentation has focused a lot on the radiographic signs.
Mm.
And one thing we must note is that, and I think I've said it, is that by the time the disease is evident on a radiograph and a chest X-ray, it's too late. The disease has established itself. So the question you're asking is, how earlier? So one way to do that is you'll notice in the Australian case where they started to use low dose HRCT.
Oh, okay.
Now, low dose HRCT is not yet available in South Africa, but we can do an HRCT. However, the results from an HRCT may not be, sorry, let me rephrase that. The results of HRCT does not have criteria set in the compensation standards at this point. However, that result will be considered together with your chest X-ray if you're making a diagnosis of silicosis. But going back to the point, the radiographs, the images are still too late. Are there earlier biomarkers that we can look at? There are studies underway that are looking at whether exhaled particle breath prints, as we call it, offers a novel biomarker approach for detecting early silica-related lung injuries. So before we get those whorls and those nodules and opacities become evident on your chest X-ray, can we detect whether there are changes in the lipids and in the proteins that are lining the airways that shows early silica dust related injury? And this work is ongoing, and actually, it's just a pilot that has started now with Wits University. But that's one way that we can pick up disease early. And symptoms, I think as regards symptoms, look, symptoms generally with silicosis appear much later in the disease. We see, patients sometimes with even progressive myelofibrosis that don't even have a cough, or they have a very mild or a slight cough. So the symptoms are not very helpful when it comes to diagnosing disease early.
Okay, thank
Thanks. I
you.
hope that answers.
Yes, Doc. Thank you so much. The next question, before we give Dr. Casper a chance for a question, how can workers protect themselves from silica dust exposure?
Okay, I think that's a very fair and valid question. So, in terms of respiratory protection, remember the whole pathway starts from a worker understanding that they are going into a hazardous environment in the first place. Now, a lot of my talk was around recognizing the hazards, recognizing that you may be prone or you may be vulnerable to the risk of getting silicosis after many years of silica dust exposure. And together with that risk of exposure to silica dust, you now are also more prone to getting TB. So when it comes to protecting yourself from the silica dust, and this is not taking into consideration all the other dust controls and the other hygiene and exposure initiatives that should be done by our colleagues in sitting in the occupational hygiene teams, being offered a respiratory protective mask is critical. So in many cases, and most times when we look at the hierarchy of controls, we say it's the last level, right? We should be substituting, we should be removing the worker. Unfortunately, if you look at a typical mine, it's not practical to remove the worker from all dust exposure if one is working underground. So short of removing them and bringing them up to the surface, working underground is going to expose you. So you should be offered respiratory protection within a respiratory protection program. So just dishing out a mask to a worker and saying, use this when you're underground is not sufficient. We got to do a whole respiratory fit test. The workers got to understand why they're using this mask in the first place. And the mask or whatever protective equipment is delivered to the worker must be shown to reduce dust levels. It cannot be an intervention that's just been tested in the market and not specifically in the mining industry. And we've seen many cases like this. And sorry, I know I'm focusing on mining, but we have colleagues from all the other sectors here. But the protective equipment that is chosen, the tool that is used for the protection should be validated for the workplace setting that you're in. And this is the where we should be working very closely with our colleagues in occupational hygiene and, of course, on the engineering side. So, long answer to a question how workers can protect themselves, but I think number one is education and awareness, is that the workers must know what environment they're going into and to take necessary precautions to protect themselves and to report it when they feel that they are being unprotected. It's like you would remove a worker from an unsafe place. So where it is unsafe in terms of an unhealthy and hazardous exposure, where it's going to impact your health, I believe workers should also exercise their right to be removed from that workplace. And again, it all boils down to education and awareness of hazards, recognition of the hazards in the first instance.
All right. Thank you very much, Doc. Dr. Casper, are you ready for your question?
Yeah, please.
Please go ahead.
Dr. Govender, thank you very much. I'm writing my college exams next month, so I'm hoping to gain some wisdom. You've already alluded to the high resolution CT, so that was one of the questions. Perhaps you can just tell me the CCMS system that OMPs are supposed to use to sort of upload the results from a medical benefit examination, and then also the the ability or the right of ex-employees and their families, obviously, in this case, to submit their organs for examination. How widely known do you think is those processes? How well are they described? Because to be perfectly honest, even sitting in a tertiary hospital, we've found that to be a fair challenge. And so it just feels to me that, you know, the obviously the upstream effects are very important, but even the downstream benefits, the people are not getting access to that compensation.
Mm. Yeah, thanks. Thanks, Casper. I'm going to respond to the last one first because that's the easier one. So the rights of families to access the autopsy compensation, that's in the Act. So dependents of deceased mine workers can sign consent and submit the cardiorespiratory organs to the National Institute for Occupational Health, and those results then feed into the medical bureau system. Now, the awareness around that autopsy examination is becomes a challenging one because of the cultural implications. The you know, how do you tell a worker? I tried this when I used to be at the occupational place. Is you tell the worker, you know, you're going home on retirement. You're not going to be coming back to the mines for your, unlikely you'll come back every 2 years for your medical examination. But you know, if you pass on, make sure your family knows that they must. It's a very, very sensitive conversation to be had. What the National Department of Health with the MBOD has done is develop a post-employment an ex-mine workers booklet. I see I do have colleagues on the call. Dr. DiPalisa is on the call, so please help. They have developed this ex-mine workers booklet, and it's very available on the it's by the Minerals Council, pardon me. The Minerals Council has published the book. It's on the website. Last year, I did some sessions at Chris Hani Baragwanath at the pulmonology unit there. And what we did was get a whole lot of books in different languages delivered to the unit. And they shared that with the ex-mine workers who attend the parapulmonology clinic. So there are huge awareness drives, but it's not easy. But we should be doing our best, I think, as OMPs, and especially as OMPs in the public sector, who should be, you know, ensuring that these ex-mine workers do access that benefit. I'm not sure exactly what your first question was around uploading the benefit medical examination results onto the CCMS that's hosted by the MBOD and RMA.
Yeah,
I'm not sure what the question was.
yeah, and how many people know about this, even amongst our OMP colleagues, you know? Yeah, it's just yeah.
Okay, I think I'm going to dodge that question because I think that's a question for the MBOD and the CCOD, and particularly our commissioner. I'm not sure how that has been rolled out. So yeah, but I think in the absence of submitting a digital, if you're not able to submit a digital submission for compensation, then it's I think you have to reach out to the MBOD director as well on submission of a hard copy as opposed to submitting the hard copies. I hope that clarifies.
Thank you.
Thank you very much, Dr. Caspar Hubert and Dr. Vanessa Govenda. Colleagues, I know this was quite a mouthful, and I'm sure with our aging brains, we were able to only remember about 10 to 15% of what was said. So we are going to post a video on YouTube by Sunday evening. So kindly please take down the number for Lebohang and reach out to her or myself to share the video link. And our next session will be on the 25th of June, 2026, when we'll be discussing occupational health stress, the exposure assessment and control aspects of it. I'm sure that's another big headache. On the closing note, Dr. Caspar, do you have your final words to share with us?
No, But just thank you very much. I really enjoyed being able to present to you guys, and I'm encouraged to see that so many people are interested in the health and safety and well-being of our laborers.
Thank you very much, Doc. And Dr. Govender, your final words, please.
Yes, thank you. Thank you very much. It was wonderful to be on this panel with colleagues who share a passion for advancing your own education, and importantly, is translating and taking these lessons back into your workplaces. I've just posted in the chat the link to the ex-mine workers guide.
All
Thank you.
right.
It's available in various languages. Thank you very much again.
Thank you, colleagues. It's here in the chat room. I'm going to leave it on for the next few minutes until the end of the session. On that note, I would like to wish you a very wonderful evening with your families until we meet again soon. Thank you.
Thank you.